I remember learning this topic from my 7th year when I was in 5th year, and now you're learning the topic from me. It's like a circle of life. Grab your piece of paper, let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at prematurity. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving such amazing content on almost a daily basis, or maybe nearly a daily basis. And grab your piece of paper and let's go. Here's a warm-up question, which is an OSCE station. Shown in the image are two twin infants born to a 16-year-old primigravida. I don't know who's getting pregnant at 16 years old, but oh wow. What is your diagnosis? List 5 complications associated with the condition. So here is the picture. You may pause the video, scream your answer at your screen, write it down on a piece of paper. I will give you the answer at the end of the lecture. So, what exactly is prematurity? Remember that a pregnancy is going to be roughly term at around 37 weeks. That's 259 days of gestation. So a baby that is born alive before 37 completed weeks is considered premature. We can further classify this into late preterm, moderate preterm, very preterm, and extreme preterm. So 34 to 37 weeks, that's late preterm. They're almost close to term. 32 to 34, that's moderate preterm. 28 to 32, that is very preterm. Then less than 28 weeks, that is extremely preterm. These ones even have a very low chance of survival. So there are some other terms that are actually used to refer to premature babies. You can use the word preterm, you can use the word preemie. So remember that premature babies are pretty much going to be at risk of a number of complications that we'll talk about, and these are related to the fact that their organs aren't as well matured or developed at the time of birth. Remember that the earlier the baby is born, the higher the risk of complications. One thing that I want you to keep in mind is that a baby is roughly going to be weighing an average of 3 kilograms. That's from 2.5 kilograms to 3.5 kilograms. And babies that are born between 1.5 to 2.5, we call that as low birth weight. Those that are between 1 gram to 1.5 grams, we call that as very low birth weight. Those that are less than 1,000 grams, we call this as extremely low birth weight. You can sometimes have these low birth weights and very low birth weights being associated with prematurity. They may also even be associated with term infants and those that are born after 37 weeks. So remember that most babies that are actually considered to have low birth weight are premature. However, you may also have other conditions that can cause low birth weight in a baby that is born at term. So I want you to keep this in mind. So babies with low birth weights that are born at term, or rather you can think of them as underweight, and premature babies whose weight is less than expected, you can collectively refer to these as small for gestational age, of which you can actually divide into 2 main groups. There's what is known as a symmetrical small for gestational age, which is abbreviated SSGA, and asymmetrical small for gestational age. Symmetrical small for gestational age, it means if the head, the rest of the body is proportionally small. Then in asymmetrical, you find out that the head remains huge, the rest of the body is small. This is really problems that are happening in the later phases of pregnancy. So some things that can cause intrauterine growth restriction include things like infections of the fetus before delivery, chromosomal or gene abnormalities. These are responsible for symmetrical small for gestational age. Insufficient nutrients provided by the placenta. These are essential for asymmetrical, because remember, the brain is a very selfish organ. The brain and the head remain the same size, and this would be at the expense of the rest of the body. So pretty much the head will be almost near normal, then the rest of the body will be smaller than they are supposed to be. Poor nutrition in the mother and other problems such as chronic disease or smoking can lead to asymmetrical small for gestational age. Now, what are some of the causes of prematurity? Remember that many factors have been linked with prematurity. Some factors directly cause early labor, whilst others are going to be causing the mother or the baby to be sick and actually requiring early delivery. So we can divide them into maternal factors, fetal factors, and factors associated with the pregnancy. Maternal factors include preeclampsia, which is an increase in blood pressure after 20 weeks of pregnancy. You may have gestational diabetes, chronic medical illnesses like heart, kidney, and sickle cell disease. You may have infections, especially with group B streptococcus, GBS, urinary tract infections, vaginal infections. You may also even have infections of the fetal or placental tissues. Drug use, especially with cocaine, abnormalities of the structure of the uterus. You may have cervical incompetency, where the cervix is unable to stay closed during pregnancy. You may also have just a previous preterm birth. This is actually more of a risk factor than a cause. You may have some collagen disorders. Then those are the maternal factors. Now, the factors that are going to be affecting the pregnancy include abnormalities or decreased function of the placenta, a placenta previa, a low-lying placenta. You may have a placenta abruption, which is early detachment of the placenta from the uterus. You may have infections of the placenta, premature rupture of the membranes. You may also have polyhydramnios, where they have too much amniotic fluid. There may also be some fetal factors. Remember, when the fetal behavior indicates that the intrauterine environment is not so healthy, you may even have multiple gestations, twins, triplets. I showed you a set of twins earlier on. And you may also even have congenital anomalies. Now, what are some of the features that we see of prematurity? So, every premature infant is actually quite different, but they may have some overlapping features. So, they may have a very small size. At about 24 weeks, the male is going to be about 700 grams. The female is about 620 grams. They have very thin, fragile skin. Their veins are going to be visible, kind of like someone who has bleached their skin. They may have the dark red color all over the body. They have these soft hairs on their body, which we refer to as lanugo. You may have a soft pinna without any recoil, and they startle to loud noises. The eyes may be fused, the eyelids may be fused. They may have infrequent eye movements. They may have a very faint cry. In the females, you may not even have any breast tissue that is palpable. Then when it comes to the genitalia, in the males, the scrotum may lack the rugae, which are those foldings. So the scrotum is going to be completely smooth. Then the testes may not be present in the scrotum. We call this as cryptorchidism. Then in the females, you may have a prominent clitoris. The labia majora will be widely separated. The labia minora will also be protruding. There is little to no activity. There is a weak cry. There are feeding problems because the baby can't really suck normally. Then, of course, there are some other breathing problems that can be attributed to apnea of prematurity. They may sometimes even be attributed to the deficiency of surfactant in the lungs. The limbs tend to be in an extended position. They may sometimes even have these jerky movements. Remember, generally, the fetus is supposed to have flexion of the limbs and some good flexion. So here is a schematic table, or rather a table that's going to be comparing someone who's between 23 to 27 weeks versus someone who's 37 to 42 weeks. Here are how the fetus is normally supposed to be, and this is how a premature infant is actually going to be. So take your time to actually go through this table. It's actually very, very self-explanatory, and the things that I've been talking about here on the left of the screen. Now, what are some of the complications? CNS complications, you may have intraventricular hemorrhage and hydrocephalus. So remember that this is going to be due to the rupture of the germinal matrix. These are blood vessels. Then this is due to hypoxic or even hypotensive injury. Some predisposing factors of intraventricular hemorrhage include prematurity, respiratory distress syndrome, hypo or hypervolemia, as well as shock. Then generally the child is going to be mostly asymptomatic, but they may become lethargic. They may suck poorly. They may have a high-pitched cry because of the increase in the intracranial pressure. They may have a bulging fontanelle. The diagnosis is usually by performing a cranial ultrasound through the anterior fontanelle. Then the treatment is going to be directed towards correcting the underlying condition. So if it's a respiratory distress syndrome, you correct that. If it's a shock, you correct that. Then in cases of hydrocephalus, you may actually put a shunt, a ventricular peritoneal shunt. You may also have hemorrhagic and periventricular white matter brain injury, what we call the periventricular leukomalacia. You may have cerebral palsy, which may cause difficulty in muscle control and stiffness. Even later on, it may result even in some learning disability, or we do not want to reuse the term mental retardation. There may be deafness, and they may have also retinopathy of prematurity. So remember that when the blood vessels in the eye are exposed to low levels of oxygen, they're going to begin to proliferate. So there's going to be proliferation of immature retinal vessels due to the excessive use of oxygen, because initially you had hypoxia and you gave this child oxygen, and this oxygen is causing now this proliferative retinopathy. So it can lead to retinal detachment, it can lead to blindness in severe cases. And remember that all very low birth weight infants should actually be screened for retinopathy of prematurity, so you should perform an ophthalmoscopic examination. So this should be done by a trained pediatric ophthalmologist, and the infants actually should be screened and should be monitored at least 1 hour post installation of eye drops for side effects from the systemic absorption of the drugs that are used, like the cyclopentolate and the phenylephrine. Then some common side effects include vasoconstriction, tachycardia, hypertension, apnea, and even feeding intolerance, which you should check for. So all infants below a gestational age of 30 and with a birth weight of less than 1,251 grams, this actually differs from different NICUs. These must be screened. So the infants must be booked for screening at 4 weeks chronological age. So you should write the date of the screening on the front of the infant's record, then provide the parents with information or an information leaflet. Then of course the ophthalmologist must be provided with a list in order of screening before the start of the screening session. Then of course treatment is with laser surgery. You may actually need this in a very, very severe cases. Then other CNS complications may lead to blindness. Now the procedure, usually ensure that the infant is fit for examination. So all ill infants must be rebooked for the subsequent week. Then the patient must be monitored via pulse oximetry. You should administer cyclopentolate in the eye, 1 drop per eye. So you should actually use a maximum of 3 drops. Then at 15 to 20 minute intervals, you should start at least 45 minutes prior to the examination until the pupils are dilated. So the nasolacrimal ducts can actually occlude when the eye drops are instilled, and this may actually even limit the systemic absorption. So dim lights should be used to minimize discomfort for the infant after the eye drops have been put. Then of course we check for adequate pupillary dilatation prior to inserting the second and the third drops. So we should actually dilate them progressively. So poorly or failed pupillary dilatation may actually be an indication of severe retinopathy of prematurity. Then benzoxynate hydrochloride 0.4% eye drops, which is a local anesthetic, must be instilled with the last cyclopentolate eye administration. Then swaddle the infant during the procedure and then place them in a nest. We should assist the ophthalmologist with positioning as required, then record the findings in the infant's notes. Then of course document any follow-up dates on the infant records and in the retinopathy of prematurity diary. So that's the procedure that we usually follow. Then when it comes to respiratory complications, respiratory distress syndrome or hyaline membrane disease. So remember that the lungs are rather immature and they are not going to be producing surfactant. Surfactant is going to be produced by the type 2 pneumocytes as early as 20 weeks, but it peaks roughly at about 35 weeks. Remember that surfactant is what actually enables you to reduce your work of breathing and prevent your lungs from collapsing when you exhale. So the incidence actually increases with infants less than 32 weeks of gestation. So the signs and symptoms are usually seen within 3 hours of birth. They may have tachypnea, you may have grunting, you may have cyanosis. Then surfactant actually is going to be containing both lecithin and sphingomyelin, which you can actually use to determine whether the fetus has reached maturity or not prenatally. So the lecithin sphingomyelin ratio greater than 2 to 2.5 is actually quite indicative of fetal lung maturity. So in addition, the alveoli are going to be small, they inflate with difficulty, and they do not remain filled with the gas between the inspiration, so they can easily collapse. So the rib cage is also weak and compliant. So it actually causes high surface tension, and the propensity of alveolar collapse is even much more. So the alveolar collapse can actually progress to atelectasis, intrapulmonary shunting, hypoxemia, and eventually cyanosis. You may sometimes have apnea of prematurity, which is due to the immature maturation of the breath centers in the brain. Remember that breathing is controlled by certain centers in the brain. You have the apneustic and the pneumotaxic centers, which are pretty much found in the medulla, or rather the pons, and then you have the medullary centers, which are the the dorsal respiratory group of neurons, and the ventral respiratory group of neurons. So these neurons are not so well developed, such that the infant is going to be having some episodes of apnea, which is cessation of breathing for more than 20 seconds, associated with oxygen desaturation, cyanosis, and or bradycardia. You have predominantly 3 types of apnea. It can be central apnea, which occurs when the inspiratory effort is absent. You may have obstructive apnea, where the inspiration persists in the presence of the airway obstruction, or you can have a mixture of both, central and obstructive apnea. Remember that apnea occurs in more than 50% of the neonates, less than 30 weeks, and the occurrence reduces with advancing in gestational age, and at 60 days post-conceptual age, the risk of apnea in neonates is actually the same as that we see in term babies. So remember that with apnea, it occurs in 50% of the neonates less than 30 weeks, and the occurrence actually reduces as the gestational age actually advances. Then apnea of prematurity is actually a diagnosis of exclusion. So you want to exclude all the other possible diagnoses. You want to exclude hypothermia, hypothermia, hypoglycemia, anemia, hyperbilirubinemia, sepsis, intraventricular hemorrhage, necrotizing enterocolitis, gastroesophageal reflux, just to mention a few. So any neonate with apnea should actually be evaluated roughly and thoroughly before you actually conclude that this is apnea of prematurity. So the evaluation, if it's a preterm neonate less than 33 weeks of gestation, we usually commence these patients on continuous oxygen. Then oxygen saturation monitors, such that we hook these on to the machine, which has an alarm, such that if the saturations dip below 88%, the alarm is going to be triggered. And then if they are not breathing for more than 20 seconds, the alarm is going to be triggered. So you have a prompt response to actually address this child who's desaturating. So if no monitors are available, it's actually quite important to observe the neonate for cyanosis, any mottling of the skin, lack of breathing, even lack of chest movements. So the workup is going to include a full blood count, ESR and C-reactive protein, glucose, blood cultures, serum electrolytes, serum aminophylline levels if possible, and a cranial ultrasound. If they're not tolerating feeds and they have abdominal distension, you should suspect that they have necrotizing enterocolitis. So what's the management? The prevention is pretty much aminophylline or caffeine. I'll give you the dosages very shortly. So this is given prophylactically to all the preterm neonates that are less than 33 weeks of gestation and those that are less than 1,500 grams of birth weight. So the dose of aminophylline, you get a loading dose of 6 milligrams per kg slowly over 20 minutes. Then we start a maintenance dose of 2.5 milligrams per kg twice a day, starting 24 hours after the loading dose. Remember that aminophylline may be given orally. Usually we reconstitute it into a liquid form to the stable preterm neonates at the same dose. Then we stop once the infant actually has good sucking and the swallowing coordination. So the therapeutic serum levels should be 9 to 14 milligrams per deciliter. Then the caffeine dose I will give you in the next slide. So when it comes to the caffeine, 1 milligram of caffeine base is actually contained in caffeine citrate. So the doses given are for caffeine base, which is the raw format that we're going to be using. Then the loading dose of 10 milligrams per kg orally, then a maintenance dose 12 to 24 hours later of 2.5 to 5 milligrams per kg per dose 24 hourly, so once a day. Then for caffeine citrate, you can give it orally at a loading dose of 20 milligrams per kg orally, and then 12 to 24 hours later 5 to 10 milligrams per kg per dose 24 hourly. Now, most references actually refer to use of caffeine citrate, and certain pharmacies actually use anhydrous caffeine, that's the base, plus water for injection, plus sodium benzoate. So the caffeine base on its own is not used intravenously, you have to reconstitute it. Then the indications for giving caffeine at gestational age less than 35 weeks, central apnea, you may have a weaning respiratory support, then you may have therapeutic trough of 10 to 35 micrograms per mil, and toxicity occurs if you have greater than 50 milligrams per liter. So 1 milligrams per liter, that's about 5.4 micromoles rather per liter. So some infants actually may benefit from a repeat loading dose or a maintenance dose. So the treatment is pretty much to establish the cause that is causing the apnea of prematurity, start the treatment for the suspected cause, commence them on CPAP, continuous positive airway pressure with close monitoring. And then, of course, during an apnea episode, you stimulate the infant. If they are not able to arouse them, then you should actually perform bag mask ventilation. Then if episodes are frequent, more than 3 episodes, then you should hook them up to a mechanical ventilator. Then other respiratory complications include chronic lung disease or bronchopulmonary dysplasia. So this will be in the setting where the child actually still needs oxygen beyond 28 days of life. So sometimes it may even be extending to months and sometimes even years. So it's going to be characterized by squamous metaplasia and hypertrophy of the small airways. And remember that when an infant has bronchopulmonary dysplasia, they can be wheezing. So remember, not everything that wheezes is equals to asthma. So the treatment is supplemental oxygen, oral steroids, and bronchodilators. Premature children may also have pneumothorax, they may have pneumonias, and take note that in the extremely premature babies, the lungs actually may be incompletely developed, in addition to them being immature, so they rarely even survive outside the womb. Those are those that are between 23 weeks to 25. Remember the 5 stages of lung development? There is a mnemonic. Every premature child takes air. The embryonic stage, which is 3 to 8 weeks, the pseudoglandular stage, which is 5 to 16 weeks, the canalicular stage, which is 16 to 26 weeks, the terminal saccular stage, which is 26 to 20 through 37. We even get some surfactant there. Then the alveolar stage, which is from birth up until early childhood. That's about 8 years. Cardiovascular complications include persistent or patent ductus arteriosus, anemia of prematurity, hypotension, atrial septal defects, and ventricular septal defects. Other systemic complications include GIT complications like necrotizing enterocolitis, neonatal jaundice, poor feeding, gastroesophageal reflux. Genitourinary system complications, inguinal hernias, are actually at a higher risk of even strangulation. You may have some metabolic complications like hypoglycemia, hypothermia, which may be attributed to a larger surface area to the volume ratio, leading to greater losses of heat. Then, of course, the skin is also immature to control heat and fluid efficiently, the fluid balance and temperature balance efficiently. Then there is also a reduction in the subcutaneous fat that is supposed to be acting to insulate this child. The electrolytes and fluid imbalance may also be there, especially with hypocalcemia. You may have osteopenia of prematurity. Other complications include rickets of prematurity, infections like neonatal sepsis, GBS infections, coliform, pneumonia, perinatal asphyxia. Here's a schematic diagram to actually show you the different types of complications, and we've talked of each of these complications in the previous slide. So you may actually take a screenshot of this and keep it with you to help you remember the different complications of prematurity. Sorry for that. So when you're taking our history and we're evaluating the patient, we generally want to ask for the risk factors of prematurity in the history. So what was the age of the mother? Is there a young maternal age? Is there multiple pregnancies? Is there an infection? Is there any maternal illness like a pregnancy-induced hypertension, any cervical incompetence, or anything in the antepartum history? Get a full obstetric history. What was the condition of the child at birth? What was the APGAR score? Was there any resuscitation required? What was the birth weight? Is it appropriate for the gestational age? If the gestation is not known, you can actually calculate the gestation from the menstrual period by an early date ultrasound or by assessment of the gestation after birth. You can use certain different types of scores. If the problem is associated with a twin pregnancy, there is actually a much higher risk of poor neurological outcome. Then congenital abnormalities or infections like chorioamnionitis may actually trigger preterm labor. So you should ask for a history of fever during the pregnancy. Ask if steroids were given, because the administering of steroids actually helps with reducing the incidence of respiratory distress syndrome as well as intraventricular hemorrhage and necrotizing enterocolitis. I've already talked of these long-term complications. I just wanted you to focus on the history here because these are the long-term complications we have actually mentioned. The only thing that we haven't talked about is the mortality rates. So 20% of infants born at 24 weeks actually survive. So this is very, very low. By 27 weeks, this rises to 70%. And after 32 weeks, the chances of survival are actually very excellent. Now, what's the diagnosis? We get a history. I've already mentioned what you're going to be looking for on the history. Examine the child for features of maturity and make sure that you examine this child and estimate the infant's gestational age. How do you do this? You use a Ballard score. So this is what the Ballard score actually looks like. This would be the top half, this would be the bottom half. I couldn't put it all on one page because it wasn't going to fit on the slide. So you fill in the name, the date and the time of birth, the sex, the hospital number, the date and time of examination, birth weight, the race, the age when they are examined, the length, the APCA score at 1 minute, 5 minutes, 10 minutes, the head circumference, and the examiner that did the examination. So as you can see here, you're just pretty much looking, what's the posture of the child? 3, you record a 3 here. What's the square angle? How much can the wrist bend? If it's greater than 90%, 90%, 60, 45, 30, and all the way. You put the score there. If the arm recoil, you pull it and let go. How much is the arm recoil? You score like that. Popliteal angle, again, you score it like that. The scarf sign, you can, like as if you're throwing a scarf over your shoulder, you score it like that. The heel to ear, you take the heel and how far can it reach the ear, you score them like that. Then you add the total score. So this is the neuromuscular maturity. Then you're going to be adding the neuromuscular maturity score over here. Then you also have some physical maturity here where you have the skin, the lanugo, the plantar surface, the breast, the ears, and it's pretty much a self-explanatory thing. So you record the total score here. So you're going to, let's say if you have a neuromuscular score of, let's say, a score of 10, and a physical score, again, you say a physical score of 10. So you're going to be saying 10 plus 10, which is 20. So if you come here and you say 20 score, a maturity score of 20, so this child was at 32 weeks gestation. So the gestation would be at 32 weeks. Don't forget to also add the gestational age by dates, by ultrasound, and by this exam. So this is how we're going to be using the Ballard score. It's also possible to have -1, -1, -1, -1. So when you come here, you're going to be subtracting from the neuromuscular score. If this here is at -1, if this is at minus, you also subtract like that. I'm pretty sure you're very well conversed with the mathematics. So this is the Ballard score, and this is how you actually use the Ballard score. Here's a chart showing you the fetal infant growth charts for preterm infants. Remember that they do have their own charts where you can plot the weight, the head circumference, and the length for the child, for the preterm babies. Now, what's the management overally? You want to admit them to the NICU for special care and monitoring. Temperature control is paramount, so the patient's actually encouraged to participate in as much care of the baby as possible, and they should be holding the child. Kangaroo care is also very important, skin-to-skin care. Then diaper changing, giving them baths, feeding them. Then, of course, total parenteral nutrition or intravenous feeds are actually advocated, especially for the very preterm children. Then gavage feeding can also be done. So the preterms that are before 34 weeks of gestation need to be fed by an NG tube or a nasal jejunal tube. Then, of course, feeding should be done by NG tube until 32 to 34 weeks when the sucking reflex actually can develop. Then breast milk is often has to be delayed. So expressed breast milk can be given in a bottle. Then the decisions about feeding generally depend on the infant's particular circumstance. Because if this infant is showing new features of necrotizing enterocolitis, you're not going to be wanting to feed this child. So you maintain the glucose above 2.6 millimoles, and we prevent infections by hand washing and aseptic techniques. So we are not supposed to be going with jewelry, with ties, with long-sleeved shirts to the NICU because those things easily carry infections. Then we treat the complications as they arise. I think I've already mentioned the different types of managements during the lecture. And in anticipation of respiratory distress syndrome, secondary to surfactant deficiency, so we can give a dose of dexamethasone before they actually give birth in the mother, assuming that the lungs are already at the terminal circular stage, where we can actually stimulate them to produce surfactant. If they are much earlier than this, those steroids will actually be wasted because they won't have any effect in actually stimulating the production of surfactant from the type 2 pneumocytes. Coming back to our warm-up question, shown in the image are two twin infants born to a 16-year-old prime gravida. So she's prime gravida, quite young, giving birth to twins. All these are risk factors for prematurity. As you can see, the child is almost the size of a Sprite bottle. So this is, of course, prematurity. Complications include necrotizing enterocolitis, apnea of prematurity, anemia of prematurity, respiratory distress syndrome, and retinopathy of prematurity, just to mention a few. I really hope you enjoyed this lecture on prematurity. If you did, consider subscribing, hit the bell notification icon, tell a friend to tell a friend. We are doing more videos on the channel, and as we are closely approaching 3,000 subscribers. Thank you for the support that you always give the channel. I greatly appreciate it. My name is Dr. Moses Kazevu. Until next time, bye-bye.